Welcome back to the morning show here on Arise News. Nigeria now accounts for 7 out of 22 global monkeypox cases, and that's according to reports from the Nigerian Center for Disease Control and the World Health Organization. This makes Nigeria the country with the highest number of monkeypox deaths in Africa and the world. As at September 13, 2022, the WHO Health Emergency Dashboard showed a total of 58,285 confirmed cases from 104 countries, with a cumulative of 22 deaths reported from 10 countries. But updated data from the NCDC shows that Nigeria has recorded 318 confirmed cases of monkeypox, with 7 deaths since January this year. NCDC stated, and I quote, "In Nigeria, we have 815 suspected cases, 318 confirmed cases, and 7 deaths this year from monkeypox. Our response continues with the development of monkeypox risk communication materials, provision of support to states with cases identification, as well as reporting." We are now being joined to delve into all those facts and figures by Professor Oyewale Tomori, renowned virologist, infectious disease expert, and member of board of the Global Virome Project. Good morning, Prof. Good to have you.
Good morning. How are you today?
Fine, thank you, sir. Good to have you join us.
My pleasure.
Should we be worried, Prof? The figures do not appear too outlandish, but then Nigeria ranks as number 1 now. 7 deaths, 318 are confirmed cases. How worried should we be?
I'm very worried, and everybody should be worried. Epidemics start with just one case, and then if you don't take care of it, it becomes a big thing. But one positive spin I can say to this is that our surveillance is working well in Nigeria. When you look at the figures from other countries, I don't think they are doing quite well. If you look at DR Congo, for example, most of their cases are regarded as suspected. Very few are confirmed. But if you look at Nigeria, a lot of our cases that are suspected are also confirmed. I think that's a step in the right direction. But having said that, the awareness we're getting is also part of the improved surveillance. But then the awareness should go beyond that, for people to know that the disease is around, and the very easy way of getting the disease through direct contact. And therefore, people should be aware of it so that we don't spread it. Imagine going out into anywhere, somebody who has, who has the disease, who has contacted a place where he has touched public places. The virus stays for quite a long time. And if we're not careful with touching our hand, touching surfaces, then we can also get infected. It's not only through sexual method that you can get it. You can get it at direct contact with who has the disease or who has a contaminated environment where you come into.
All right, Prof. Tomori. Of course, you talk about awareness, and in the interest of constant sensitization, and for those who still don't understand clearly what this is, let's walk you back a little bit and ask that you please talk us through what exactly monkeypox is.
First of all, I think the name monkeypox is an aberration. It's not the disease of monkeys. And that's where the first awareness needs to come. So you don't have to contact a monkey before you get it. We believe that the original source of the disease are rodents, squirrels, rodents, those type of things. That's where the virus is. But unfortunately, we're not done enough studies to be able to pinpoint and say the rodents are the original host of the virus. You remember the first case that was reported way back in 1958 was in monkeys which were actually imported from Singapore into Denmark. So it had nothing to do with Africa. But since 1970, we're having the first human cases in DR Congo and also in Nigeria, 1971. And then nothing happened in Nigeria between 1971, I think we had one case in 1978, and then nothing again on 2017. Now, this is a disease which comes, as you said, you come in contact with the virus, and it comes like every droma disease of most viral infections. You have the headache, joint pains, particularly with these ones where you have swollen glands, and then you have rashes coming upon the body, which end up in the pustules and the vesicles that we see. Those vesicles contain a lot of virus, and therefore when it breaks, it contaminates the environment, the cloth, the bedding, and everything. And if you come in contact with that, then you too can get infected through that. And it's also it is be spread through the respiratory route. And so these are some of the reasons why people need to be very, very careful.
Professor, is there a case for vaccination, and how successful is the quest for vaccine? Now, a report says Nigeria may not acquire vaccines until next year. How will this affect the effort to contain this disease? I know that no single monkeypox vaccine has been administered to any high-risk group in any African country at this point.
If we get the vaccine next year, we'll be very lucky. But let's forget about that. I think the issue of vaccines and things, the same thing that played out with COVID is the same thing that will play out with monkeypox. So I think Africa should just begin to think, not depending on charity, not depending on equity, but to begin to do something for itself. When WHO declared the emergency, it was 50 years too late for Africa. And it was even 2 months too late for Europe, because Europe had already gone out and started doing what they need to do. After the world declared the international emergency, America went and declared it its own national emergency. They didn't wait for WHO to do that. So I think there's a lesson for us in Africa. We can't be waiting for international agencies to declare for us, before we take action. But having said that, vaccines, I think we need to balance it. The disease has been around in Nigeria since 2017. And I think we had about 500 cases, although the number has gone up now. Total now, we have had almost more than what we had over the period 2017 and 2021 we have had in this year. So having look at that, the disease really is a matter of, it is spread. If you can identify the disease, isolate the patients, practice your infection prevention and control, then you can actually limit the disease. It's a self-limiting disease. Vaccines do help, but I think our focus should be the awareness we're talking about. Since we are not even going to get the vaccine, then let us do what is within our capability to do. Identify the disease as we are doing as quickly as possible. Get our laboratories to confirm it as quickly as possible. Isolate the cases as quickly as possible, and then make sure that the health workers and other people do reduce the direct contact between such people. That's going to pay us more than waiting for the vaccines. And when the vaccines come, anyway, as I said, if we get the vaccines next year, we'll be lucky. So let's use what we have now. Awareness, create that awareness, identify disease, isolate the cases, ensure infection prevention and control. And because it's a self-limiting disease, we can actually put it under control. You remember I said between 2017 and 2021, we only had about 500 cases. Things are not getting much more the case is now occurring. But take a country like DR Congo, where the surveillance is not as good. They actually report more cases, suspected cases, than we do. Unfortunately, less than 10% of them are confirmed. So our advice is, let's forget about vaccines for now, because we're not going to get it. Let's focus on what we need to do, which again, I'll repeat, quick identification, isolation of the patients, infection prevention and control, avoid direct contact as much as possible. And that's all.
Okay, Prof, how is this disease, how does it relate to smallpox in any way? Any correlation? And if there is, do you get any form of protection if you've been vaccinated against smallpox?
Yeah, of course. I mean, they are the same pox family. Smallpox, monkeypox, rabbit pox, cowpox, all sorts of, they're all pox in the same big family, each one affecting its own species of body. But then when we come together, then we can get the rodent pox and get it to human pox. In the days when there was a lot of smallpox vaccination, which I think stopped way back in 1980, people who got the smallpox vaccine are actually protected. Up to about 80%, 85% of those who get the smallpox vaccine are protected against monkeypox. But you remember, the world has eradicated smallpox, but smallpox vaccination has stopped since 1980. Therefore, the generation that was born after that time now are actually not protected. But even for those of my age group that got the vaccination, 50, 60 years after that, your immunity has also waned. So we're a little bit more, maybe a little bit better protected, but the generation that was that are totally, unprotected against smallpox. So that's where I think where we're getting this upsurge of cases that are coming.
All right, Professor. Just to get some clarity from you, as we know, monkeypox has been declared by the World Health Organization health emergency. But at the same time, messaging from the NCDC has been to the effect that there is really no cause for much alarm. Now, in light of these conflicting messages, could we get your take on which is which? What's the actual situation?
Well, there are different reasons for declaring something a national emergency, either because of the spreads in different countries and nothing. Actually, the public health emergency that was declared by WHO was more because a lot of these cases were spread in European countries. Let's be frank with ourselves. Maybe it would not have been, it was not declared since 1970 when we've been having it in Africa. Why suddenly in 2022 was it declared public health emergency? Because literally thousands, hundreds of European countries were having the cases and popping up in different areas. But yeah, we knew why it came about that. It was obviously associated with some change in the behavior of our people, sexual transmission linked to male sex, that kind of thing. I think in a way we are studying, we don't have that much in our own environment. I'm not saying there's no male sex to sex transmission within the country, but it's not a major route of infection. Our major route has been the direct contact. And that's why I think our NCDC has been focusing on the fact that, look, if we can avoid this direct contact, then really, it has not been an emergency with us since 2017. Why suddenly now? Like I said earlier on, WHO's, if you remember, the declaration by WHO was actually against the decision of the committee that WHO set up. It was almost like an overruling by the WHO director general himself. So, and like I said, it was too late for Africa. It's too late even for Europe, which already started taking action. And then what is it going to bring to us? We're not going to get a vaccine. So at the end, I look at it, what is the declaration of the emergency? What has it brought us? Nothing. And that's why we in Africa should begin to look at our own situation and say, how can we ensure that this thing does not spread? And basic, simple thing. Let's not wait for if the vaccine comes, okay, it's an addition. But if it doesn't, then let's do what we have done between 2017 and now, why the disease has not spread as fast. I think we are relaxing. And as I said, yes, there's improved surveillance, but I also believe that we're not taking care of those look like what we had with COVID. Keep wear your mask or whatever. Same thing with this one. Hygiene, wash your hand, avoid contact with the people who have the disease, and things of that nature. We're going to be better off, following that than waiting for any vaccine that she say would. Let me not say never come. May never reach us for a long time to come.
Going? All right. Well, Professor, earlier you alluded to the fact that the human-to-human transmission of this disease could spread by close contact and exposure to the infected person, and that the virus can stay in one's body for a long time. Now, how long does it stay? And really, what is the treatment? How do you actually get rid of it once you get it?
Well, how long it stays in the body depends on the climatic environment where you are. If you are in an air conditioned room, like just normally, it will probably stay out there for quite a long time. As to how long it depends on the humidity, the temperature of the around. If you're out in the sun directly, of course, it doesn't last that long. So again, like I said, you cannot put a time to how long the thing stays around. It's there, and the better the condition around for it, good humidity, good temperature, the longer it stays in the body. As for treatment, I remember when they used to give us a the itching and pain. So keeping the person clean is probably the only. There are few drugs which are not really against pox generally, pox viruses generally, but they are very expensive. They are not easily available. So we are back to those basic tenets of hygiene and maintaining and all that.
All right, Prof. Let's take a look at the status quo in terms of preparedness on a broader scope. Could you please speak to the country's current biosafety measures and diagnostic capacity?
Well, you know, when COVID started, they told us we had only 3 or 4 laboratories that could diagnose. Now we up those numbers up to 100 and something. Our problem is sustainability. If you go back to the NCDC website, they have a list on a page where 60 to 70 of the so-called labs we have set up are no longer functioning. That's not the way to prepare. The first question is, do we really need 140 laboratories in the country? No, I don't think so. Then should we not have just limited ourselves to what we can maintain and sustain? What's the essence of 70 labs not reporting or not even testing anymore? But then, of course, I understand our country. The upsurge, anything that's had to do with contract, you can trust our government will be there. So everybody was building labs. Sometimes they build a lab, they did not equip it. Sometimes they equip it, they did not staff it. And that's where we're having the problem we're having. We could have safely done with fewer labs, make sure there's accessibility to all the people have access to those labs, and they have enough resources to maintain them constantly. When the next epidemic comes, if we continue at the rate COVID is going now, and I can give you another 1 year, more of those labs will no longer function. So when the next epidemic comes, we come back, Nigeria has only 20 labs to let's build more. Let us sustain what we have. We don't have to build labs in every state or every nook and corner. The polio eradication initiative for the African region had only 15 labs for the entire African region. And these were maintained and they are still being sustained. That's what we need to look at. It's not one lab, it's not a federal character type of thing to put lab in everywhere. Have labs in easily accessible so states can make use of it, and we have enough resources to maintain them. And that's the problem we're having. So when you're talking about preparedness, unfortunately about preparedness, you can prepare as much as you prepare. It's the exam that determines whether you are well prepared. When the next epidemic comes, in spite of all the noise we're making about preparedness, we will know whether we are prepared. But in my own opinion, I don't think we are. And my reason for that is the fact that preparedness should be done, downloaded, not downloaded, what's the English word? Be cascaded down to the state level and the local government level. Our National Center for Disease Control should actually be a National Center for Disease Coordination. Activities should be at the state level, should be at the local government level, so that the NCDC can coordinate and help all those people. So we have the facilities very close to the people, not located in Abuja or whatever, And that's the problem we're having. Let the states come up together and get all these things in place. Support those laboratories, support their disease surveillance. Why should a state be begging the NCDC to come and investigate an epidemic in their state? It's dereliction of duty by those states. Each state should have the facility to have the diagnosis. We had it before in the 80s. Well, what has happened to us?
All right, Prof, just a bit more on the nature of this disease, monkeypox. I know that it's not necessarily a death sentence, but then if a patient comes out of it, if you've been exposed and you come out of it, does it confer a kind of immunity on you, or is this something that you can go through like COVID twice or thrice within a particular time?
No, luckily, this is quite different from COVID. The rate of mutation of the virus is not as much as what you have with COVID. I mean, you get variants and some variants of concern. The virus that cause pox, they are what we call the DNA viruses. They do not mutate as much as. So whatever the immunization you've gotten will protect you from future cases. Just like yellow fever. You remember, yes. We get yellow fever and say come back after 10 years. No, not at all. I think monkeypox and the pox virus are actually the same. People like us, you got vaccinated, you show I still have the mark of my vaccination, and I got protected for that. So luckily, this is not like the one that mutates and changes and have variants. So once you recover from the disease, the likelihood is that you are protected from future infection.
Well, that's good to know. Let's talk more on symptoms. According to NCDC, some of the symptoms include, swollen lymph nodes, fever, and a rash that might initially be mistaken for chickenpox. Now, how can an infected person tell the difference between chickenpox and monkeypox at first sight?
You are probably not being able to tell. You probably will have to go, with any rash at all, should go straight for diagnosis. I mean, go to the lab to ensure that we can differentiate between chickenpox. Even there's measles rash. But again, the distribution of the lesions also play a part. With monkeypox, you find it on the face, on the hands, on the body, even on the sole of the feet. So, but then you're not going to wait to get to that development before you start looking for diagnosis. Any infection that comes with any rash at all, I think the first thing is go into the hospital, get your lab confirmed to be sure that this is not chickenpox, but is monkeypox. So my advice is, again, that's why the importance of the laboratories become important. You remember I mentioned the fact that a country like DR Congo reports like thousands of suspected cases based on the clinical science, but their laboratory diagnosis is not as good as in Nigeria. In our own case, we are doing much better in terms of laboratory diagnosis and confirmation. And that's where we need to go. So anybody who has any of these that come up with rash, goes please to the hospital, and then they can then probably help you with proper diagnosis about what exactly it is. That is a monkeypox rash and not another kind of rash.
All right, Prof, as we approach the end of it, let's just talk about these numbers that we have in terms of fatalities and the cases. Could you speak to the accuracy of this data? Do you have faith in these numbers? Or could they be bloated or... Yeah.
No, I think to a large extent, apart from a few countries in Africa region, I would think the data is okay. Well, if you look at the global data, they are much better than we are in the West about disease surveillance and things. So you can take their data as almost accurate. We're Nigeria, I would say we are in between. We're doing well, we're improving, we're not really the best, but certainly our diagnosis has improved over the period. We haven't reached where we should reach. I would not compare our data with, say, DR Congo. There are thousands of suspected cases. We can only confirm less than 10. So, generally, let's focus on Nigeria. I think we can abide or we can accept the figures we have. But I think with the improved surveillance, I'm sure there are more cases that we're not yet seeing. So, if you're looking at the figure, I think it's not really. I think there's more outside there than we are reporting. Let me put it that way.
All right, Prof, before we let you go, what will be your thoughts on what a lot of people consider to be the good news from the Federal Executive Council regarding the approval for the first stage of indigenization of vaccine production? As you know, the federal government will now, they now have a technical partner from India. Do you think that this is something worth celebrating at this point? And what would be your advice as they move forward towards vaccine production in Nigeria?
For once in my life, I'm a very excited Nigerian over that information. I'm telling you that because I've been directly involved in all the things the federal government was announcing. Only last week, actually, the partner from India came, we went to see the minister about it. And so the news came together about the time when the government announced this. The issue of the 15% supply of vaccines by Vaccine Nigeria Limited and Serum Institute of India is a step in the right direction. But I tell you, it has been a battle we have been fighting for the last 15, 20 months. But we are making progress. But I wish now that we have opened this door, progress will be made much faster. I'm very optimistic that soon, I mean, if we follow up all this and all the normal bureaucracy of government is overtaking, I'll be one of the proudest Nigerians to say we begin to produce our vaccines locally in a very short time. That is, I can't give you the dates yet because each time you turn around, there's one obstacle on your way. But the thing is not to give up. We'll continue to fight. We've been fighting for the last 2 years, and we got to where we are. And I think now that we've opened this door, things will move faster than they're moving before. So kudos to the federal government. And again, hope that this will be a great thing for our country. To me, it has been a shame that all these years we have been depending totally on everybody. My last point to say that Africa must begin to realize that equity is not begged for, not pleaded for. Equity is fought for. That's number one. Equity is self-interest, basically. Let's not deceive people. Because the Bible says, love your neighbor as yourself. It didn't say love your neighbor more than yourself. So you love yourself first. And when there's a crisis in the plane and the oxygen mask is dropping, what do they advise you? They said, take care of yourself before you take care of your child. Africa must begin to look at equity in that time, that until we contribute to equity, there will never be equity, even in a fair world. So it does not, we cannot be consuming the crumbs of equity. We should contribute to equity.
All right, Professor Tomori, we want to thank you very much. We all remain just as hopeful as you have mentioned earlier. Thank you very much for joining us this morning and discussing this very pertinent topic. It's time now for a short break, and when we return, it will be time to begin the build-up to tomorrow's funeral of Queen Elizabeth II's. Arise special correspondent Judith da Silva is standing by to bring us up to date. Stay with us.